Hi, this is Dr. A with a clinical chemistry review video on pregnancy and prenatal testing, and we're going to look at diseases associated with the developing fetus. So we're going to start with neural tube defects. So these are abnormalities of the fetal central nervous system in which there's a failure of the neural tube to fuse. So there's usually a problem with the development of the spinal cord or the brain. It is one of the most common birth defects seen in the developing fetus. There are several types of neural tube defects. The most common are spina bifida, also known as meningomyelocele. And that one, the bottom of the neural tube does not fuse. We have encephalocele, and this one, there's a sac containing the brain and the membranes from spinal membranes. They protrude through an opening in the skull. And in anencephaly, there is a lack of parts of the brain and skull, so they just don't even form. Because of these neural tube defects, then a fetus will have a limited lower extremity mobility and sensation. It will have neuropathies of the bowel and the bladder, and it will have possible renal issues. This is correlated with folic acid deficiency, as in usually supplementing with adequate amounts of folic acid helps prevent the development of neural tube defects. But you have to do this early on, and I would say even possibly like before conception. You have to make sure the mom is got a good and adequate amount of folic acid in her diet, or even if it's through supplementation. So we screen for neural tube defects with alpha-fetoprotein levels. They can be part of a triple or quad screen. This is often done in the beginning of the second trimester of the pregnancy. And if they're elevated, then you can suspect neural tube defects. The next complication or problem is Down syndrome. So Down syndrome is an extra copy of the long arm of chromosome 21. The characteristics of a Down syndrome fetus will include some mental deficiency as the baby grows, hypotonia, congenital heart defects, so those are usually known as the tetralogy of Fallot, and they will have also a flat facial profile. The maternal age severely increases the risk of having a fetus with Down syndrome, especially if mom is older than 35. Or older than 40. The older she is, the higher the chances of having a baby with Down syndrome. There is also a condition that's kind of related to it. It's trisomy 18 or Edwards syndrome. And this one occurs when the fetus receives an extra copy of chromosome 18. What you have to know, though, is that there's an estimated that 80% of the fetuses with trisomy 18 don't live past 8 weeks gestation. So they don't even make it out of the first trimester. And then 70% of them don't make it past the second or third trimester. Half the newborns with trisomy 18 will die within 5 days, and 90% of them will die within 100 days. How do we screen for these trisomies? So for Down syndrome and Edwards syndrome and other trisomies. So we do the triple or the quad screens. They both include data about the risk of fetal Down syndrome and can detect over 60% of cases. So if the quad screen is abnormal, then further testing is going to be indicated, usually chromosomal analysis, maybe an amniocentesis, to see exactly what's going on with the baby. So what do we mean by abnormal, and what would indicate either a Down syndrome or an Edwards syndrome fetus? So we are looking for low levels of alpha-fetoprotein, low levels of unconjugated estriol, high levels of beta-HCG, and high levels of inhibin A in the second trimester. So those could indicate possible Down syndrome. And that's what we'd be looking for in the quad or screen or the triple screen. The next one is hemolytic disease of the newborn. This is also referred to as isoimmunization. It involves a fetal hemolytic disorders that occurs when the maternal antibodies are directed against fetal erythrocytic antigen, meaning mom is making antibodies to the baby's red blood cells. Okay, this occurs when the mama is Rh negative, and so she's O neg, A neg, B neg, or AB neg, and she is carrying an Rh positive fetus. So this would happen if dad was Rh positive. And then what happens is mom gets sensitized to the D antigen, which is the Rh antigen, because she's carrying an Rh positive fetus, and sometimes there's a little bit of mixing of mom and baby's blood. So then the mom develops antibodies, and those antibody titers go up, and this is really more of a risk for the red cells of the second Rh positive baby. So there's usually not a problem with the first pregnancy, because that's when mom is sensitized. This is and this can occur sometimes simply from birth, because there's a lot of blood and bleeding during birth, and so there can be a mixing of mom and baby's blood, and then mom could be sensitized to the D antigen, which is the Rh antigen. And but then by that time the baby has been delivered, the first baby's been delivered, so everything's okay. So in her second pregnancy, though, her titers of those antibodies are up, and they can cross the placenta and attack the second baby, and then this is where you can have fetal demise, and pregnancy is not being carried to term, or the babies are born in distress. And so this is detected by an increased bilirubin in the amniotic fluid of the second pregnancy. Right, and one of the ways that we can prevent this is at 28 weeks and post-delivery. If mom is Rh negative, we can give her anti-D, which is the RhoGAM shot, and that is given to the mom to prevent this. So that prevents her from being sensitized to the D antigen. And so we would do that for every pregnancy. She would, if she's Rh negative, you would automatically do that at 28 weeks. And then if she gives birth to an Rh positive baby, then you would definitely do it post-delivery. Now, if mom gives birth to an Rh negative baby, you don't need to give her the post-delivery one, but you will give her the 28 weeks one, because you don't know what the Rh status of the baby is at that time. And you have to do this with every pregnancy for an Rh negative mom. So the next one is respiratory distress syndrome. So this is usually a result of preterm delivery, when a fetus is delivered earlier than the 37th week of gestation. The problem is the lungs cannot produce enough surfactant, and the alveoli can collapse during exhalation. So they take their first breath and inflate their lungs, but then when they breathe out, the alveoli kind of start collapsing. They have a hard time reinflating them. So the symptoms of respiratory distress syndrome in a baby is going to be hyperventilation with or without cyanosis. So there would be like a bluing of the lips and the tips of the fingers and toes and nose and ears, etc. There will be nasal flaring and exhalation grunting. So they're really working hard at breathing, also with intercostal retraction. So it's like you can see they're struggling to inflate their lungs to suck air in, and it's really obvious. So one of the things to do if we suspect preterm delivery is to do a fetal lung motility test. The current practice is to perform a phosphatidylglycerol test, or PG test, as a screen to see if the lungs are mature enough for the baby to be delivered. If this test is negative or low positive, then a lecithin-sphingomyelin ratio could be ordered. And if the baby's coming anyway, then the mother may be given some steroids in an effort to mature the fetal lungs. If we know that these lungs aren't mature, it is also possible to give this pulmonary surfactant to the baby as soon as they're born. All right, so that wraps up our fetal complications. I'll see you in the next video.